So welcome everyone. My name's Professor Peter Nash from Griffith University in beautiful downtown Brisbane in Australia. And I'm delighted today to be joined by Professor Iain McInnes, CBE. Professor McInnes is known to everybody far and wide. He's the Vice Principal and Head of the College of Medical Science, Medical Veterinary and Life Science at the University of Glasgow, where he holds the Muir Chair of Medicine and the Versus Arthritis Professor of Medicine. A glittering career, including EULAR president, he's known to all. Welcome, Iain, and thank you very much. Today, we're going to be discussing a topic that was highlighted in the recent EULAR meeting in Barcelona quite frequently from a number of groups, and that's this discussion about what they define as difficult to treat and complex to manage. And so welcome, Iain, and we'll have a little discussion about this particular topic. Terminology is important. I'm not a fan of difficult to treat. If you tell a patient they're difficult to treat, they'll think they're being a difficult patient, which I'm not sure they would appreciate too much. But we could call it treatment refractory, for example. So welcome, Iain, and how are you doing today?
Oh, I'm absolutely marvelous, Peter. Absolutely marvelous. Just enjoying the Northern Hemisphere summer in all its glory in Scotland. So I rather suspect you're enjoying more pleasant climate in downtown Brisbane than we are in Glasgow. But there we are. There we are. Great,
All right.
great to see you.
Let's talk about this difficult to treat thing. Give us your feeling, because at EULAR, the EULAR guidelines for defining difficult to manage and treatment refractory was presented. GRAPPA presented the results of their work. A lot of this stuff is driven by consensus and a systemic literature review. ASAS has a definition of difficult to manage, rheumatoid that you penned. What's your feeling about this concept and where we're going with it?
It's complex, Peter. Let's start by whether we need to have a concept at all, and then we can think a bit about what we're going to call it. And I would strongly advocate that we do need the concept of that person with disease whose quality of life continues to be significantly impaired, at least partially as a result of having that disease. Now, I've chosen pretty much all of those clauses pretty carefully, Peter, because, and I, in the rheumatoid world, there's somewhere between 6 and 17, 18% of patients with rheumatoid. When you look at the big registry, the real world evidence is not the long-term extension studies. Ignore them. That's not what we're talking about here. We're talking about data that come from where real rheumatologists see real people who have real disease. Now, the problem is that in the clinical trial world, we now talk about remissions. We talk about ACR70s. We talk about MDA. We talk about ASAS40s. We talk about all these outcome measures, and they're progressively higher hurdle. And as clinicians, we look at each other with a vaguely satisfied smile on our face and say, aren't we doing well? And yet, there's a whole lot of people out there who are not actually really doing as well as we'd like them to. Now, I'm not talking about the 30, 40, 50% of patients who are not in low disease activity remission. That's not today's discussion. We could have another podcast and talk all day about that. This is a group of people who, despite sequential therapeutic approaches, are still in a state whereby their quality of life, their relationship with the disease is fractured. Now, so I think those people clearly exist, and they need to be acknowledged. I'll pause for breath there, because we can think about what we call them, and we can think about the reasons that they find themselves in that situation. And I think in either order, actually, because that's where the terminology becomes clear. But I would certainly be very strongly of the mind that this group of human beings exist and are really struggling. And as Lord Thomson, William Thomson, Kelvin himself, Lord Kelvin, I should say, that just finished his 200th anniversary here in Glasgow. He said, if you can't measure it, you can't manage it. I've slightly paraphrased the great Lord Kelvin there, but we need to start. We need to start by acknowledging the problem is there, quantifying its prevalence, and then thinking about how we define it and what we're going to do about it. So those are my opening remarks, Peter.
Understand, and I think it's driven by two aspects. One is that people get endlessly cycled through biologics, one after the other, without a thought to whether there's other comorbidities or other issues driving their particular problem, which is where I think this whole movement began. And then there's this aspect that we never measure levels of our drugs in the non-responder to see if, in fact, they're resistant to that therapy, or in fact, we haven't reached a therapeutic level. It's like treating epilepsy with never measuring a Dilantin level, similarly. What's your feeling about measuring levels? And thirdly, our outcome measures are so influenced by pain with all its different dimensions, physician global, patient global, etc.
Wow, lots in there. Well, let me start with, ironically, the one measurement that you didn't mention, Peter, but that's just to be a contrarian Scot for a moment. Do you know the most important thing we never measure is the molecular quantity of inflammatory disease. And that's the fundamental problem here. We rely on surrogates of inflammation, a patient history, and quite often they do pretty well actually in describing what's going on. Ultrasound, MRI, which are useful but blunt tools at best. And we don't really have a molecular quantification, a CRP, an ESR, with all of the legion issues of non-specificity that we are very familiar with in and around the acute phase response. So the first thing to say is that actually quantifying inflammation per se is a difficult measurement. And I'm going to grant you that a CRP and an ultrasound image or an MRI are a whole lot better than not having a CRP or an imaging measure. So I think, and I actually, this is one of the areas in rheumatology where I am quite enthusiastic about using imaging to define intercurrent inflammation. Then there's the second thing we should measure is once a drug is administered, have we administered it in sufficient concentration in that individual, cognizant of their pharmacology, pharmacokinetics? And in that's again one of the few circumstances where measuring a drug level of some kind is probably worthwhile. What I would suggest to you, and there are a few studies, we saw them at EULAR this year, EULAR last year. Yeah, there are a few studies that suggest that knowing the actual level of drug can be helpful, but the discriminant value in defining how well somebody's going to do is still pretty low. So I wouldn't go to the barricades in this if people feel that measuring drug levels is helpful. If we were to measure a drug level and you find no drug, methotrexate being a very good example, the polyglutamates, you've got a pretty good idea that your patient's not actually adhering to the drug. Biologics is a bit more difficult. I think, and you can keep me right here, but my understanding is that adherence to biologics is generally a bit higher than to some of the other disease-modifying drugs we've tended to use in the past. Notwithstanding that, there will be different pharmacology for how monoclonal antibodies and other protein receptor constructs are handled. There are differences in the way these drugs are turned over. They're not huge, Peter. You know, we don't have the same dramatic effects that we have on the way small molecules are handled by extrusion pumps and the rest of it. So in that context, measuring a drug level just to be sure you've got a therapeutic concentration in there might be useful. But here's another unknown for you, not for this morning, but do we actually know what concentration of biologic drug is in the tissue? And sure. And everyone just says, oh, of course we do. And then they stumble and mumble when they go and try and find the literature. And one great paper, Frank Kolbinger, a few years ago, put microtubules into psoriatic plaques and measured an anti-IL-17 antibody in there. And apart from that, we pretty much don't know what happens when that biologic meets the endothelium and gets the opportunity. So yes, drug levels on occasion. And that's certainly before you give up drugs. I suspect we give up medicines a little too easily, just in general. And that's maybe for everyone, not just the difficult to treat or difficult to manage patient. One of the things we should always be cognizant of if we're taking on young patients with a chronic disease for which at the present we have no cure, we do need to be thinking about, I'm going to have to make decisions with you for many years to come. Let's make each decision carefully. So, and I think in that respect, Peter, I think you make a great point. We need to cherish our medicines, cherish each choice, and be ever so careful with them, and make sure that if we do discontinue medicine, it's for the right reason, either not tolerant or genuinely inefficacious with an appropriate dose having been administered.
Well, I think your point about inflammation is super critical, because all the definitions from EULAR, from GRAPPA, from ASAS hinge on the division between refractory and complex to manage, where they have pain issues, fibromyalgia, etc., is driven by the objective evidence of inflammation, and they're talking acute phase reactants, clinical signs, and imaging. And I think you've already pointed out the pitfalls of those particular measures. But that seems to be the key that decides if you're a refractory patient or a complex to manage with these other metabolic and extra-articular features.
It's a great point, Peter. I couldn't agree more with every single word. Might be worth just, let me use that as a segue to let's just focus for a moment on this idea of refractory. I must say, until quite recently, when I was thinking about patients who were requiring serial immune targeting therapeutics, I did use the word refractory. And when I used the word refractory, conceptually, I was thinking about an immune state or an immune pathologic state, that is where the tissue and the immune system are talking to each other. And that conversation is impervious to our therapeutic. In other words, there is a state of therapeutic resistance. Now, that might be because the body has worked out how to resist the drug, or it might be that the pathogenesis has evolved under pressure from the drug. Think of the famous evolution experiments we all learned about at university, the grey moths that changed colour with industrial pollution. Does the disease change under pressure? And the pressure is not pollution. The pressure now is the presence of a drug, a perturbation in the system. TNF is blocked, therefore other pathways need to be found. Think of a river delta overcoming and bypassing an obstruction. And that, I think, that does exist. I'm not sure we know which of those two possibilities it is, by the way. It's probably both. It's probably both. And I think there are a subset of patients who have genuinely refractory inflammatory tissue disease. The problem, and I just wanted to highlight, you make such a good point about the other things that cause people to have poor quality of life. It is, by the way, one of the reasons why, although I respect the PRO community's desire for us to use PROs extensively, PROs signal a patient's poor quality of life, or for that matter, good quality of life. What they don't necessarily do is signpost why that quality of life is impaired. And that, for me, is a huge problem. So let's just think, what are the factors? There's comorbidity, and that comorbidity can be in the cardiovascular system. The comorbidity can be in muscle. The comorbidity can be in bone. Think osteopenia. Think accelerated osteoarthritis. And I don't know whether OA is a comorbidity or just a consequence of chronic inflammatory damage. Honestly, you're dancing in the head of a pin there. The consequence is the same for the patient. Pain, dysfunction that's not likely to be responsive to a directed anti-inflammatory approach. And then there's the psychosocial element. I've had chronic disease. I'm out of work. I've split up with my partner. My children are unhappy with me because I'm always unhappy with them, even though I love them. There's the financial penalties that come with that. And we know that people in the poor socioeconomic groups respond less well to medicines, require more cycling of medicines, and in the long term, take a higher proportion of the health economic burden in society. We know that once you've failed a couple of drugs, you could be forgiven for being a poor adherer to therapy. This doctor doesn't know what they're doing. They keep giving me medicines that don't work. Well, do you know what? Why should I bother? Why should I take the risk of a side effect? This is not having a go at our patients. Quite the contrary, Peter. I think a lot of this difficult to manage, difficult to treat discussion is having a long, hard look at ourselves and thinking about how we parse out the challenges that patients face when they're with us. And then finally, back to the beginning again, there is this issue of treatment resistance, which is where you started with drug levels, where there is actually resistance to the treatment itself. So all of those parameters need to be considered. And you know, so I used to think about treatment refractory as being pretty much the inflammatory tissue problem. But when I really reflected on that over several years, I realized that was a very inadequate definition in my own mind. It was a very, it was a misleading way to think about the challenges our patients face. And ultimately, it was going to be it was going to lead to treatment strategies, which we'll come to later, but it was going to lead to treatment strategy decisions that were probably misguided. I'm probably giving the wrong medicine for the wrong reason. And that's the absolute opposite of what we're aspiring to in the future that will eventually be some kind of strategic treat to target with a little bit of wisdom thrown in as to what medicine to use when and how. And again, I'm going to pause for breath there, but those are, you prompted a bit of a download there, Professor Nash. Thank you for that. I feel much better now.
Well, look, I think it's critical, this complex to manage, where you have no objective evidence of inflammation, because it doesn't mean you don't treat them. You just treat them with non-biologic monoclonal antibodies. You treat them with pregabalin, with all the physical therapy, surgery, injections, a million other things, treat depression, etc. Work on sleep disturbance. So I hear you completely.
You treat them with the art of medicine, Peter.
Exactly, exactly.
Art of medicine. Think of it as art therapy. Now, there's a lovely thought that we can send right around the globe this early July morning.
Yes. Well, tell me this. I'm very interested in this concept of chronic widespread pain. And in a condition like the axillary spondyloarthropathy, PSA in particular, where there's so much widespread enthesitis that we don't even manage, we don't even examine, I mean. So how do we know that what we label as fibromyalgia, in fact, isn't a lot of widespread soft tissue inflammatory enthesopathy?
Well, we have to rely on the relatively primitive imaging modalities that we have available at the moment, Peter. And I say that with a deep level of respect for the experts in our discipline who are using imaging and taking the field forward and constantly improving our understanding of how we use sophisticated MR. I mean, in the longer term, I'd love there to be some kind of derivation of safe molecular imaging. Think whole body PET in due course. That's not remotely for routine practice at the moment. So at some point, we will have really quite sensitive, sophisticated detection methods. I don't think we've got those at the moment, Peter, in terms of the widespread, genuine low-grade inflammatory causes of pain. So I'm going to just simply grant you that I don't think we're good enough at that yet. With the proviso, though, that if the clinical description of pain is only partially satisfying with that as an explanation, we should be thinking much more widely. And this issue of fibromyalgia, fibromyalgia is an unfortunate name, isn't it? Because it carries so many connotations. I quite like this idea that Neil Basu, Dan Claw, and others are prosecuting around sort of nociplastic pain. The idea that we start to appreciate that the nervous system reprograms in the presence of chronic disease, chronic immune diseases, and that reprogramming leads to changes in the way different nuclei connect within the brain, different pathways become active, the balance in which pathways work, the balance in which different neurochemicals work changes. And of course, you'll notice now, no surprise that I, as a very biologically based clinician, I would hope I'm always holistic and to treat the person rather than the disease, as Hippocrates advised us. But at the end of the day, there will be molecular pathways that define the concept of pain. And I think, Peter, we are closer now than we have ever been That's one of those. That's one of those kind of silly phrases. Of course, we're closer now than we were before. Although, you and I have played golf before. And in fact, to our wonderful listeners and viewers, I have to tell you that Professor Nash nearly killed me with a kangaroo by sending me into the woods on an Australian golf course, in amongst the kangaroos, to find the golf ball. It wasn't worth it. Anyway, the problem with golf, of course, is if you're too close to the ball after you've hit it, that's a problem. And I think, we're probably still a bit too close to the ball after we've hit it with quite a lot of interventions in pain, Peter. So nociplastic pain is giving up its secrets. There are amazing functional MR studies that Dan and Neil Basu and others are doing, whereby the patterns of neuroconnectivity, the way different nuclei connect with each other and functionally interact with each other in the brains of patients with immune-mediated inflammatory disease, particularly inflammatory arthritis, those pathways are now revealing themselves. Now, this is, again, just be clear, not yet for prime time clinical use. But Peter, it provides very compelling evidence that the use of drugs that we have at the moment, like pregabalin, you mentioned that isn't a sort of Hail Mary approach where, oh, nothing else works, I better just try and treat you for pain. That, Peter, is a tacit recognition that there are molecular events going on in the skin, or the enthesis, or the joint, but there are molecular events going on in the dorsal root ganglion, in the ascending tracts, and in the brain, and those molecular pathways are just a lot less well understood. But that does not mean that in future we'll not be able to target them appropriately. So I actually say that to patients. I say, look, you're not making this up. This pain is not some concoction of your imagination. This pain comes from molecular adaptations in the brain, just as your body has had molecular adaptations in the skin or the joint. I'm not sure the word molecular adaptations works very well in the East End of Glasgow, by the way, but we find ways of explaining that. But I think it's very important, Peter, because, and you'll understand, of course, the challenge that we have as biologists. So let's circle back to something we said earlier. Refractoriness. It might be that there is indeed molecular refractoriness in the brain, and that's what's driving nociplastic pain. It might be that there is molecular refractoriness in the cardiometabolic system, and that's why our patients find it really hard to lose weight. There is adaptation of the way in which adipose tissue has changed in time. Adipose tissue is an inflammatory tissue. It's responsive to the immune system. Remember, it's a huge source of energy for the immune system in the fight or flight response. So I think ultimately, here's the irony, we will probably get back to calling this molecular refractory disease, but we'll do so with attention to the different tissues. And until that time, I really like the concept you've laid out of thinking about different comorbidities alongside the primary tissue targets, and being very sentient with your patient, be very aware with your patient to say, look, it might be that inflammation isn't causing all of the things that are challenging your quality of life. And on that basis, it might be that we shouldn't necessarily be throwing another biologic at this. It might be we need to sit down and have a long chat. We maybe need to talk to the psychologist. We maybe need to talk to your family. We maybe need to just get a few kilograms off your weight, please. And it might be that will achieve more than another medicine. And here's a factoid that you can use with your patients. If you look at the recent North Star study, which looked at first choice biologic in people with rheumatoid. There was a huge effect of body mass index and your likelihood of achieving response. That, by the way, is a finding that has been reproduced across numerous studies over the years. But the difference in response, Peter, if you try to get that difference approved, if it had been a medicine that achieved that, you'd probably have got it approved. So I don't know that for a fact, by the way, so don't quote me on that bit of the podcast. But you get a sense of what I'm saying is that there are large magnitude gains from dealing with other parts of the syndrome that is being human. And if sure, our patient has a high BMI, there's no point in ignoring it. It might feel like a difficult conversation in the short term, but in the long term, your patients will thank you for it.
Well, let's circle back to that exact point you made about therapies, because part of the definition, whether it's ASAS, GRAPPA, EULAR, the RA, they've decided that the definition must include failure to maintain or achieve response to two biological targeted synthetic DMARDs of two different modes of action. What's your thoughts about that kind of bar that people have to jump over to fit this kind of definition?
Yeah, well, of course, and I should just state for the record, I'm an author on the RA points to consider and definitions, and because I was an author there, I didn't particularly get myself engaged in the other diseases, but I think there's a lot of learned people involved. I think this is about trying to get us to think sequentially about what's going on in the patient. And if a patient hasn't had an anti-inflammatory trial, I'm cognizant of your comment about drug levels, by the way, but if a patient hasn't had a sufficient anti-inflammatory trial of therapy with at least a couple of MOAs, then I would feel very, very uncomfortable saying you've got difficult to treat immune disease because I've not actually treated you yet. So that for me is one of the most self-evident of the definition concepts. Two MOAs, we debated that long and fast. Two is a number that happens to be a wee bit higher than one and a bit lower than three, Peter. I'm not sure the science was much smarter than that. My only defense of it would be that we do have patients in whom we try mode of action A and we don't get a response, but when we try mode of action B, we do. So we've all had that clinical experience where we take someone, they get a TNF inhibitor, and then we move them on to, I don't know, a JAK inhibitor, 6-receptor inhibitor, and the latter respond, the former was a non-responder state. So I think giving at least two MOAs a fling is a good place to start. In real practice, it might end up a bit more than that before people start to think we're in trouble. You've also got to think about why people are failing anti-inflammatories. Intolerable drug injection site reactions, intractable nausea, a liver function abnormality. Those are all things you'll see written down in the adverse event profile and reasons for discontinuation of biologic as well as small molecule drugs. So what is that teaching us? What is that telling us? It's possibly telling us that those targets, inflammatory immune disease targets, have not been adequately interrogated. But there were other reasons that prevented us really getting in about those pathways. So I think thinking about an inflammatory hurdle that has to be passed before someone is classified as complex or difficult is the baseline. And then you'll see, if you look at the rheumatoid definitions, that there are other things that go in there. There's that we've talked already about imaging signs of inflammation. We've talked about the acute phase response and all its wonderful brilliance, because it is simple and cheap, but it has lots and lots of provisos that go with it.
Yes.
We've
Tell us a little, Ian, about your thoughts on the failings of our outcome measures. You've mentioned it briefly, but surely there's kind of a ceiling effect with whatever we give people, and I'm sure it's driven by our outcome measures.
You're trying to get me into trouble, Peter. You know that. The outcomes community and I have a wonderful friendly relationship, but we do sometimes disagree with each other. And I'm sure that's due to my failed understanding of the process. But let me start by saying that I think the progress in outcomes research in rheumatology in the last 20 years has been transformative for the development of new medicines, and I have to say, the development of strategies, think, treat to target. So my starting point on outcome measures is that outcome measures are a very, very good thing. But like any other good thing, if we're going to improve, as in the leopard, if things are to remain the same, then everything must change. And if staying the same is that we're going to continue to progress, then I think we are going to have to change. So let's interrogate the outcome measures. I think the biggest elephant in the outcome measure room is the concept of multiple different contributors to a single composite outcome. And what that means is that you can fail to meet a target with think an MDA, think an LDA or a remission state with whatever of your favorite outcome measures you're talking about. The problem is that that tells you that the patient's not in that state, but it doesn't tell you why they're not. And I'll use the easiest example, although actually, if you think about this across the range of immune-mediated inflammatory arthropathies, this is actually true of all of the diseases, but I'll use the easiest example, which is psoriatic arthritis, and the MDA, which is a terrific device. The problem is if you use MDA as a target and your patient's not at that target, it doesn't tell you whether they're not at the target because their skin disease is horrible, their enthesis is horrible, their synovium is horrible, their state of mind, their depression, or whatever. It doesn't tell you what's happening in the totality. Yes, but the tissue microcosm. And if every medicine we used treated every tissue, that wouldn't be a problem. But that is a problem if different drugs have different propensity for benefit in different tissues. So if we go back to the best of all the trials, which is Tycosa, it's a great study. But it's very interesting that Tycosa has been neither reproduced nor confirmed. And that's because it's a really, really hard trial to do. So all credit Laura Coates and Philip Helliwell. It's a really difficult trial to do. And I think it's been very, very helpful and influential in our discipline. But, you know, if MDA is your target and the patient's skin disease is pulling them down in several areas, including an unwillingness to believe their joints are any better, and your next escalation is sulfasalazine per protocol, well, you know, that doesn't treat skin disease. And so, and one of the things about Tycosa is that, you know, it had more SEEs than the usual intensive strategy arm. Now, this is, I want to be critical here, this is not having a go at Tycosa, quite the contrary. It's a fantastic study and it's kind of pioneering. It's led the way in the field of PSA, but it makes the point beautifully as to how difficult it is to escalate the therapy for the right tissue. And I think, for me, the future is outcome measures that are sensible and composite. So, yeah, take the composite, the failure to meet the composite strategic target, but then go back to that and work out which bit of the composite drove the problem, and then make a strategic decision on that basis.
So that's why I'm a bit against composite indices in complicated pathology, and for a domain approach. I know it takes more time and I know it's unpopular, but a domain approach will help us exactly what you're saying. Now, we started therapy, so we're going to talk about implications for this discussion. Are we going to find predictors and treat people combination early if they've got bad predictors? We've got to do all those trials. What's your feeling about the implications of this definition? Treatment refractory and complex to manage. And I'll just add one other point. The patients who were involved in the EULAR discussions were very keen not to be described as difficult to treat, rather treatment refractory. But your thoughts on the clinical implications, predictors, and combinations from day one in the bad prognosis?
Yeah, okay. I'm not going to comment on the patient's views. They speak well for themselves, and I respect that view. I actually quite like complex to manage the more I hear it used in the community. And I can well understand why somebody wouldn't want to be called difficult. They won't be called difficult from the outset, but their disease might be called difficult after a while. So I think we've already made the point, Peter, that every initial decision needs to be made with a view to the long term. I often say to my patients, I'm treating two people today. I'm treating you now, and I'm treating the you that we want you to be in a decade. Patients understand that. That concept works very, very well with people. So from the outset, we should measure prognostic factors. By the way, Peter, the only area I disagree with you in your domains is that it takes more time. We routinely go through every domain, and the patients are quite good at it. They get their weight and blood pressure done before they come in. They chat to the amazing clinic nurses who do a far better job than most of the doctors. So they already come in with a cardiovascular domain thought about. We do measure cholesterol, and we engage with primary care to make sure that's done. And then you simply work your way around the joints. The joints, the enthesis, you talk about the bowel, you talk about the skin, you talk about the nails, you talk about the hair, you talk about the eyes. And you just go through it. And most of the time the answer is, no problem. and you move on. It takes 20 seconds. By the way, the patients get very used to that domain-orientated approach, and they get quite quick at it as well. In fact, quite often, once you really get to know people and they get to know you and you run your own dedicated clinic, psoriatic arthritis clinic being a good example, I'm using that as a go-to place because conceptually it's the easiest to understand. It's quite interesting. The patients will come in and say, look, I know this is an arthritis clinic, but I just wanted to mention my skin's really bad at the moment. They've got it. The patient's got it. So I think that patient, I have to say, I think the patient voice in these discussions in EULAR has evolved a bit, Peter, because we clearly had a lot of patient involvement in the original difficult to treat. And just to be clear, the patient voice was very clearly heard in that original definition. I'd be very happy if we moved forward and thought, you know, complex to manage sounds like a good treatment. Refractory, you see, is wrong. Treatment refractory makes an assumption about why the disease is refractory. Refractory disease, we maybe need to go to the thesaurus. And by the way, we do need to be very sensitive what patients about it. But we maybe need to go to the thesaurus. But if we can agree in complex to manage, that I could certainly meet you there. And complex to treat, actually could meet you there. Whether we like it or not, we are making treatment decisions. And as my physiotherapy colleagues always remind me, the decision to prescribe physiotherapy is a treatment decision. So, you know, I think, I don't think we're going to solve the definition issue today. We're just airing it. And I'm
Sure.
probably taking the prerogative to sit in our fence here. Anyway, time is against us here, Peter. Time is against us.
So I just want your quickly thoughts on clinical implications and combinations, future strategy.
Oh, combinations of therapy.
Your thoughts on the implications of this work. Are we going to find predictors that'll make a difference, or should we treat them differently?
Yeah, that's a great question. Well, I'm going to say that the field doesn't know the answer to that question yet. So I'm going to venture into hypothecation and procrastination, which is, I can hear some of my friends saying, you're not venturing in there, Ian, that's your normal place. So in my normal place of imagining a future, I think there could be people, Peter, whom we identify early on the basis of defined features that could well include, by the way, features outside the conventional musculoskeletal cutaneous system, in whom we would be able to make quite early adjudication with the patient that things were potentially not going to go well. And then we would start. Now, if the not going to go well was early signs that there was development of nociplastic pain, early signs that there were additional psychosocial factors impacting and influencing, you'll see I've not immediately jumped to pharmacology, Peter. I will in a moment, don't worry. My natural instinct will get me back there. But I think as clinicians, I'm going to go back to Hippocrates. It is better to know the person who has disease than the disease that has the person. Now, I would love to know a lot about the disease, but it's more important, and it's important in the early days, Peter, the starting point of your relationship. If a patient comes in with a BMI of 35 to the new onset rheumatoid or psoriatic clinic, if you don't sit down and say right from the outset, look, I'm really sorry, but the fact that you are a little overweight here is going to get in the way of everything that we talk about for the next number of years. And it's the first time I've met you, and I hope it's okay we talk about this. I always ask permission to have that discussion, of course. So you seem very down indeed. Have you been depressed for a while, or is this something you've talked about with other people? Do you know what I mean? Is this a preceding condition? So in fact, Peter, we need a much more holistic prognostication for people with autoimmune diseases. And then, yes, I'll finally get to the area of biological challenge at outset. And that, I think, we need to do trials on remission induction, remission maintenance, and those may very well involve probably temporary approaches using combinatorial therapeutics. And yet there I've come out and said it. Now, please, for those watching this podcast, do not do anything outside the license of any medicine. But I do think, I mean, and here's a very good example. We already know this, Peter. Think JAK inhibitors. JAK inhibitors are polycytokine inhibitors. They are, by definition, in the olden days, if we combine two biologics, we'd say that was combination cytokine inhibition. Well, JAK inhibitors inhibit several inflammatory cytokines with the same medical intervention. And actually, it's kind of clinical trial significant. I don't think we're ready to say it's clinically significant in routine practice. But these drugs are very effective when compared with a mono TNF inhibitor, for example. So I actually think there will be value in biological, not biologic medicine, but biological combinatorial approaches, so long as they're combined with very imaginative strategic approaches. The last thing we want is patients left on combinations of medicines when the combination is not necessarily long-term. And it's interesting, neither of us have used the G word, glucocorticoids, because remember, they even crept into definitions in places because they're so widely used. But I'd really hate it if long-term we ended up in steroids. That would be a disaster. So those are my thoughts, Peter, for what they're worth this fine day.
So thank you very much, Ian, for your time. We greatly appreciate it, and we hope people have found this discussion interesting. If you'd like to keep up to date on this topic and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available on the IMID Forum website. Please subscribe to the IMID podcast on Spotify, iTunes, or other podcast media. Let us know what you think. You can watch us on Immune-Mediated Inflammatory Disease Forum on YouTube. You can follow us on Twitter, LinkedIn, and Facebook to keep up with all the latest and new immune-mediated inflammatory disease content coming in 2025. Thanks again for your time, Ian. Greatly appreciated.
Lovely to see you. Lovely to see you. Thoroughly enjoyed that.
All the best.
Take care. Bye.